you're going to have to create a business and do really well with it. I like the idea. I think it's a fantastic idea. And, I'd have no issue of doing an in-network deal. And then we see as you grow.
Welcome to the Healthcare Grind, where we cut through the noise in the healthcare industry to bring you the latest trends, innovations, and insider insights. I'm Jess Hearthcock, and I'm joined by my co-host, Lon Hecht, as we embark on a journey to connect early-stage healthcare companies, payer executives, and investors with the knowledge and perspectives that matter most. Get ready to grind in the fast-paced realm of healthcare innovation. And for more advanced content, go to healthcaregrind.com.
Good afternoon, everyone. This is Lon Hecht from the Healthcare Grind. It's great to be back again. Unfortunately, I don't have my co-host with me today, Jessica Hearthcock. She deserved a hard-charged day off, but I do have a fantastic guest today. That guest is Mike Ruiz de Somocurcio. Mike and I have known each other for probably about 8 years or so, going back to the Teladoc days when I was at Teladoc. And he is an executive that has a vast amount of experience, and we're very fortunate to have him on the show today. So welcome, Mike.
Thank you very much, Lon. Looking forward to this.
Great. So, Mike, just a little background. Mike is currently with Vytalize. Better yet, why don't I let you do a little background on yourself? If you could share maybe Vytalize and a little bit about Aetna and kind of high level, that'd be great. And then we'll jump into the episode.
Fantastic. So I am a Vytalize employee for a month. I'm only a month in, but in this role, I am the president of their IPA for New York and New Jersey. For folks that don't know, that the IPA is a large organization of physicians in New York. We have about 2,500 providers, so very large, vast partnerships with plans. So we have different value-based care deals in the commercial MA Medicaid space. And with Vytalize's help, very active in the ACO REACH and MSSP space. In New Jersey, we have ACO REACH and MSSP practices as well. Prior to that, I was the chief network officer for Aetna's New York and New Jersey markets. In that role, I had medical cost responsibility and contracting from a network standpoint for all provider types in New York and New Jersey, and also value-based care. I did get to work very closely with a number of startups in that role and capacity. Also on the advisory board of DHNY, which is a Digital Health New York entity as well, who has a lot of experience with startups. And then for years prior to that, on the health plan side, probably for 10 years in various regional, national, and startup health insurers, including Oscar, and was also on the provider side. So have a good experience on both sides of the table, and really, really lucky to see all those perspectives for sure.
Well, thank you for the background. When you were at Aetna, you were dealing with all lines of business, correct? Commercial, Medicare, Medicaid, all across the board?
Commercial and Medicare for almost, my entire time there. Medicaid ended up coming under me probably the last 6 months. So yeah, it ended up being all lines of business at Aetna.
Okay, great. And I just think it's good as you know, our guests, or I'm sorry, not our guests, our audience, our earlier stage entrepreneurs, investors, healthcare execs, and it's always good for people to have that right lens that when we're talking about this, we're talking across different lines of business. Before we jump in, one last thing. You mentioned ACO REACH and MSSP. Could you give 30 seconds to a minute to our audience on what that is and how they're just different? Maybe I know a minute's not going to get you really deep on that, but kind of a high level if you can.
Yeah. So I think, if you look at any of the demonstration projects, CMS really wants to have providers in value-based care programs. So if you look at it, it's very prevalent in the Medicare Advantage space, working in conjunction with health plans. But Medicare also has fee-for-service members. So in essence, let's say a member does not choose a Medicare Advantage plan, they're enrolled in traditional Medicare fee-for-service. Medicare would like to see that membership managed as you would see under a Medicare Advantage value-based care plan. So they are looking at these types of models. They have different financial incentives. They're heavy on primary care and really looking to put more risk on the providers who are able to accommodate those populations and make the investments that are required. So it's not easy work, but the potential upside can be more, and the potential upside can be with the primary care providers who have normally a small overall proportion of healthcare spend.
Got it. Thank you. Really appreciate that. And little shout out to Vytalize. You all are doing incredibly well in ACO REACH. You've got to feel really good about your growth over there. So congratulations on that.
Thanks.
So we're going to talk today. The episode is really about getting in network. So typically when I think of an early stage company has a great idea and they want to go to a health plan, or they want to go to an IPA or an ACO or someone, and they want to get reimbursement for what they're doing. And there are multiple ways to go ahead and do that, right? What I'm going to do today is we're going to focus on how do we get in network? And I think there are two different paths we can talk about here. One is if you have a really innovative service that maybe a health plan or an ACO or someone else has not really done before, which I'll just say is more challenging because you don't have something to base it off of. And then the other path is, you're in the behavioral health space or you're something where there's already reimbursement set up. So it becomes a little bit easier. So Mike, dealer's choice, what would you like to start with?
I like to start with the hard stuff first. Let's tackle that.
Let's start with the hard stuff. So can you enlighten us a little bit about what does that look like? So I'm an early stage company. I've got an innovative idea. I come to you. I want to figure a way to get reimbursement for this. How do I even start? Like, let's go, let's start at the higher level and then maybe let's start going into the nitty gritty a little bit.
It's very difficult. It's a long sales cycle, as many folks know. You have to get to the right person. Exactly. And it's really important who you're touching base with. So when I would get these calls, and I would all the time, obviously Aetna's a large payer in New York, and most of the pitches initially were, hey, we'd love to take over risk in a population, or we'd love to do a value-based care deal. These are really difficult things for plans to want to start new or from scratch. And I would tell the startups that would approach me like, and I would be transparent about it. That's a very long sales cycle that requires a lot of experience. It's probably not the best idea as a new company to be even trying to get into those deals or programs, especially when you're starting up because the expectations are large. So my advice always was, why don't you start with an in-network arrangement? Now, those are difficult to get as well. You have to find the right person. I was a big champion of that with a lot of the startups in New York. So when they would approach me, I'd say, hey, Ed is not in this business to kind of create a business for you. You're going to have to create a business and do really well with it. I like the idea. I think it's a fantastic idea. And, I'd have no issue of doing an in-network deal. And then we see as you grow. That's one avenue. I'd also tell folks to say, hey, listen, there's employers are making decisions and bringing solutions to Aetna. So if you're a startup, you want to have a lot of different kind of sales options and cycles. You don't want to just rely on the plan, right? Or rely on the employer or rely on, state government. You want to cast kind of a wide net to be able to have a lot of discussions. And what I saw is that over time, some of those businesses actually based on those discussions and arrangements ended up changing, maybe their initial focus. But you want revenue to come in. The revenue coming in enables you to then, continue growing the business or investing in it. You don't want to wait for that one sales cycle that never comes in. That's, an indication of death for some of these startups that have never gotten over the ground it becomes very risky for sure. So you have to, I will say though, you have to find that person at the plan that is buying into it, innovative enough to say, hey, there's not really a lot of risk here by doing a traditional fee-for-service deal. So you have to find those champions, and it's tougher at some plans than others. I was a champion and I led the market for Aetna. So, I think it was easier to get a deal with Aetna as for those companies than maybe other health plans, but that's really key and critical for sure.
So who are the right people? Let's start there. Who are the people that the audience should be thinking about? And I'm not going to speak specific to the IPA or Vytalize because I don't want to maybe give the keys to the castle to everyone for you. But, let's talk about a large payer or another ACO or an IPA. Where would you start with that? What is high enough? How do you, you need somebody that's got the juice to be able to get something done. So where do you go?
Yeah, it is true. You want to find the network lead for that plan for sure. I think that's probably the highest level of success. It also they can bring mass scale. So sometimes there's, I was working with folks that may say, hey, we can also have national access. So if you're a startup, you want to go individual markets because some of them will make their own decisions. But if you have a platform maybe for a national contract, again, you're casting your net across a couple different opportunities and options. But you want to find, your VP of network management, your director of contracting, your chief network officer, like I was, SVP of network. Those are the roles that are going to end up making the contract decisions for sure. So that, those are the roles that people should be looking at and trying to understand. Now, it is hard to access those folks. Sometimes folks may look at consultants or other opportunities to work with plans. I did see some success in that as well. Sometimes that may help, but those consultants would in essence be interacting with all the people I mentioned anyway as well.
Okay, so and you mentioned something before. So let me jump back and say, one, you said you should try regionally, but you should try nationally as well. So you want to cast as wide of a net as you can. I think that's really good
Correct.
advice for people to be thinking about there. Another thing you mentioned kind of the employer route a little bit earlier, kind of lightly. So are you saying that our audience should say, well, we're going after plans, but maybe an easier path in is to get a couple of employers on board that get excited and want to utilize the service and maybe use them as a way to get back to the plan? Is that what you were kind of alluding to?
Yes, 100%. Because most national plans, Aetna, Blue Cross, Cigna, United, they are mostly self-funded. So there's a difference of plan membership. So a fully insured member is in essence the plan is taking risk. For a self-insured member, that employer ends up making the decisions. So for large plans, an employer may say, hey, for a solution for fertility or maternity or musculoskeletal, we work with this client because we like their navigation system and we like how they interact with patients and we like their platform. If that employer brings that to Aetna and says, hey, I want to use them, Aetna's going to have to use it as part of that overall solution. So yes, I would say those are very good channels. I do recommend to those folks that I speak with that they should, look at utilizing that. They're very similar sales cycles. They're long sales cycles. But if there's an opportunity to, again, get scale on the opposite side of the equation, I think that adds a lot of benefit to their overall business model as well.
Gotcha. So now what do you do in the situation where you have a model and you know what your costs are, right? But then you go to a plan like Aetna or United or, Cigna or anyone, and they want to give you a rate that's not financially sustainable for you right off the get-go. So I'm not talking about something that's very simple, like, a certain level visit for, behavioral health or primary care, not something like that, but something that's a little different, right? And I know that my cost is $300 to deliver the service, yet Aetna wants to give me a rate that's $150, which is like 80% of Medicare or something like that. Where do you go with that? So like you want to take that deal to get in the door, but every visit you do is putting you underwater further and further, and you have to look to your investors. So what do you do in that? How do you show that value so you can hopefully get that rate up?
I like this question a lot, and you're right. You'd have to demonstrate value, right? And that's
right.
At the end of the day, like plans are interested in improving outcomes and access, but also lowering cost. So some of these models could be, hey, we're doing something in a freestanding setting, and obviously New York is a high cost market. There's a lot of academic health systems. There's the overall costs, and with consolidation has increased in the market. So if there's a lower fee schedule or an aspect of, hey, if done in this setting, it's 2 to 3 times less than it would be in a hospital setting, I think payers really would gravitate toward those types of models and would look to negotiate. So I think you're right. Like there has to be a value prop, of an ROI, either maybe a better member experience or an option that's more member friendly or navigates the member to making the right decision. Those are all things that really resonate with plans. If a startup solution comes into play and it's like, well, it's going to be 20% more than the current options that you have, it doesn't improve the outcome. Like I've seen those presentations as well. And yeah, that's those I don't even bring in the network. Yeah, now they don't go far at all.
So you mentioned probably a fee-for-service arrangement is the way to go. But once again, let's take a scenario like we just talked about where your costs are $300, Aetna's saying you're at $200, and you're saying, well, let's figure out a way to do a little bit of a value-based construct, although you did just say that value-based gets pretty complicated, right? And it can really extend a sales cycle. Is there an in-between there where it's like, we're not going full value-based care on you here, but we'll take the $200, but we get $50 for every gap we close, or I know that's a big number, but or something like that. Is there a way to bridge it that doesn't turn you into a 2-year sales cycle?
Yeah. So even at a plan like that I was at, I would say anything that's outside a normal claims process or a VBC arrangement that we would have, if we had to create a new one, you're going to lose like myself. It's just the value of it, of the time to, navigate a large entity like that, to create a one-off for something that may not have, an ROI would be very difficult to do. I will say there are a number of different startups though that may have that. There are, navigating patients for certain really high chronic cost conditions. CVS had a venture arm. CVS would invest in some entities as well. That's an easier avenue to have a pilot done if you're being invested by the health insurance company, right? So you would see some of that too. But you want to make sure that you're if I'm a startup, you're working within the constraints of the plan. If you're starting to say, hey, if things need to be built, I will say like the network people you're talking to are probably not going to invest the time in it, because keep in mind, the overall dollars of the system, they're going to look to spend time on things that are impacting the system a large amount of money if they're going to change structure and process and systems. So
that makes a lot of sense. So rather than try and find a value-based construct, you would say find a way to prove value in an ROI and just focus on getting a higher fee-for-service rate to get started. And then, a year, 2 years down the road, start saying, hey, how do we talk about more of a value-based structure here?
I would agree. We've seen some of those models where that's actually happened. If there's been a conversion to more of like a pilot or broader use of the arrangements. And I think those are win-wins for folks. I always say like, there's no need for perfection, from the start, right? Like, again, build the business, get the revenue in the door, hone the pitch, have real world experience, but also real world findings of how the solution, again, is making people's lives easier, getting better outcomes, lowering overall costs. If that comes, I think you will see, and you see the evolution of some of these models, whether in the GI space, the cancer navigation space. Yep. These are folks that have started out like either pilots or, fee for service that have gravitated to more over time based on the engagement and the performance they'd had.
Interesting. So you mentioned the word pilot, right? To some people, that's a good thing. To some people, it's not a good thing. One thing I will say is an early stage company, time is always the biggest thing. You're always up against time, right? So when you think of something that is maybe an in-network type of arrangement, how do you structure a pilot? Like, can you give me an example of what a pilot might look like for something like that? Just so maybe the audience can get their head around it.
Yeah. So outside of fee for service, so a pilot in, a general, what you would call like maybe a VBC type of pilot. Is that what you're asking?
Well, I wasn't sure if you were talking about there's a way to do a pilot in a fee for service, right? Like if you were trying to get in network, would you say we're going to do this for up to like 1,000 patients or up to $2 million, and then we're going to come back and we're going to look at it? Do you look at pilots that way, or is it just you get in network, you're in network, and the story is over?
For the fee for service side, it would be like, certain time periods for sure. So we wouldn't necessarily like do it on billings. But, I think you evaluate like what's happened. Is there a lot of member engagement over the last year? What can you tell from that membership? That's for sure. As it relates to like other types of pilots, there are models where, depending on what type of startup it is or company, that you could have like what's called an operating advance, and that's money paid out, upfront or monthly, whatever it would be. But you're allocating all of that. So you're paying them upfront, but they're putting at risk that payment to make sure there's savings associated with it. Those models are pretty prevalent as well. But again, you have to be really, your product needs to deliver in those models, because that money that's upfront will help kind of fund the work. But if there's not the savings that are promised, then that's given back. So in essence, you end up with zero into those scenarios, and that may not be a good place to be.
So you're saying there could be a scenario where you're getting an upfront payment, you're delivering the service, maybe each fee-for-service use comes out of that payment, and then there's a period where you're looking at data to true it up at a later point to make sure that the savings were there. Okay, and then
you
just
can
for
do
the
a
audience,
fee-for-service or like an engagement fee too, so like something like that. There are different models there.
Okay, and since we're trying to be very educational, if you were to do a true-up on the back end, can you explain what a true-up is, and then how much claims run out and kind of what claims run out is? Could you give an understanding to the audience so they get that?
So true-up just means if you're looking at, okay, maybe this company says we can have 20% savings and for GI cases, let's just say, for anyone they interact, right? So you're creating a baseline of the function. You're looking at data. Usually plans like 3 months run out. I think that is pretty consistent. Sometimes you see plans use more than that, but it really should be 3 months run out, so it's not such a long cycle. But you would look at all those billings and cases and you look at those members and what really happened compared to the baseline before. If there were additional savings, then fantastic. There's an opportunity for folks to share in that. If there's enough savings, maybe the operating advance stays with the startup. If there isn't, maybe that allocates back. But those are, lower risk models for health plans to look at, especially with some of these de novo type of companies and arrangements for sure.
Right. And claims run out, just for the audience, that is after it's a certain amount of period on the back end that allows claims to come into completion so that you have an accurate standpoint. Because if you looked at a 6-month period and viewed it on 6 months in one day, you'd probably be missing 2 or 3 months worth of potential claims in there. So you want to have that time on the back end for everything to show up that really should show up. So really appreciate your help on that one. So you talked about the more difficult ones here, right? Let's talk about your standard old kind of, you're a company, like there are a lot of companies, and I keep going to behavioral health because there are a lot of them that have come up because there's such a shortage of behavioral health care workers, folks like that. There are a lot that are trying to do network plays, really aggregating. So they want to come in and they want to get in a network. What does that look like for them? Is it a standard rate that you typically reimburse, and is it end of story, or is there a negotiation there? Can you help us understand that?
Yeah, and I think BH is really important to kind of hit on. I think prior to COVID, you're right, access was a big issue. Most plans sometimes will delegate their networks. Again, it's kind of that model of there not being enough access. But during COVID, you saw really an explosion of telemedicine behavioral health companies. Aetna partnered with probably 20 to 30 of them. So I do think there's an opportunity, especially in something where there was low access, to expand and create opportunities to come into network. These arrangements, I would say they're probably not standard, market rates. But keep in mind, because there's a lot of them too, you're not going to see a lot of variation of where they end up, but there would be an overall number that kind of makes sense for that. But I think any plan, those are mostly fee-for-service arrangements for sure. But any situation with virtual exploded, even for other things outside of BH, access is really key, and timely access. So, one of the things with behavioral health, I think, is that you can maybe get an appointment like 6 months later. With some of these virtual options, it's as short as 2 days. And I think, what plans are trying to do is really develop options that consumers are driving toward, and they are driving towards convenience. So I do think, you will see more of those types of models. And I think those are fee-for-service arrangements that plans are definitely interested in moving forward, of solving an access issue, at a competitive rate for sure.
So if you were an early stage company and, you were saying, I know behavioral health, and I went there because it is a big issue, but if you had a vendor that came in and said, hey, we can provide behavioral care and we can guarantee that 95% of your patients will have access to an appointment within 24 or 48 hours or whatever that is, does that qualify you for a better rate? And how would you leverage that into a better rate? Because obviously there's going to be additional costs for you as a vendor on that to be able to have that kind of capacity. So a standard rate may or may not apply there. So how would you think about something like that?
I think if there's an opportunity to make the process faster for access for a patient, that's real world value. The question I would have is, how would you measure that though, right? So how are you going to end up measuring that and what that looks like? I do think the options, thankfully, are much more plentiful there than they used to be. So again, when you see a lot of options, there's a difference of, the range of different price options probably narrows a little bit more under that example. But for sure, I think, there are certain arrangements. Aetna would have our preferred providers for some of these things that would do just that. And you are seeing, I think, certain plans develop their, they have broad networks, but there's preferred providers for certain types of service lines. And, they'll also use those preferred providers. We mentioned the employer market before. So if CVS or Aetna has a list of preferred providers, they may advocate to the employer like, hey, you're looking for a solution. Here's one we integrate very closely with. That integration and connectivity is really, really important for when you're managing populations too.
What would be reasonable in terms of a time frame if you had something that was a fairly standard offering and you wanted to get into network? What does the process look like, and how long does something like that typically take? And I'm talking about standard. I'm not talking about coming in with something completely innovative that people are going to look at you like you're a little crazy at first. Something that's pretty cookie cutter.
If you have, it goes back to the key. If you have someone that you find at a plan that's willing to listen, understands, is open to these types of things, I don't think it'd be a long, strung out negotiation for a lot of these. But normally, like the credentialing time can vary with plans, but maybe 30 days of back and forth kind of discussion overall of what the reimbursement should be. Once that information's in, then you're talking about a credentialing time of like 60 days. Now, that's if somebody's open to doing these models and bought in. Like, that's your perfect scenario. I think what you normally see, though, is to find that person at a plan may take like 9 months to a year. And then again, the structure. So it can be anywhere from like, I would say what I've seen, anywhere from like 90 days start to finish to 18 months. It's that long of a variation. So it's really important to find, that advocate at a plan or at an employer that can help.
So you bring up a good point. I'll ask a question. Maybe you can point us in the right direction. Is where is a good place to interact with these senior level network folks? Like, you think of like industry specific people. A lot of people go to AHIP or they, go to HIMSS or something like that. But are there any specific meetings that you think of that network folks tend to gravitate towards? That could be high value for the audience to know about.
Yeah, you don't see a lot of of that. You see more of that on, I guess, the sales side more than the network management side. There are local entities, your HFMA conference, AHIP. Those are like trade shows that, you do see membership there. I think that's important. The channel, I would say, is actually really key and critical is probably LinkedIn. It's an avenue of a lot of folks have found me on LinkedIn, and I was always willing to listen. I didn't always do a deal, but I think that's a really, because you can go into the certain territories, you can say, literally put in those search words, VP network contracting, network contracting lead, for the plan you're looking at in whichever market, we'll also look at, maybe national contracting leads in certain for certain plans too. But I think that's a really strong avenue of, hey, I'm looking for this. Or, there are certain folks, again, that have plan contacts, consultants and others. That's sometimes that may be a good investment if you need to make an entry into a market in a fast enough way. But a lot of folks find me on there. And again, if people are going to be responsive, that's a low cost channel to get, there's not a lot of upfront cost to go on LinkedIn and ping some people and get some deals.
You're absolutely right. You mentioned consultants. If you were to search Google for a consultant that could be helpful with that, what would you type in?
Managed care contracts, consultants for providers with health plans. I mean, usually it's like it would normally be called managed care consultants. That's probably the best way to look at it there. Yeah.
Okay, good. It's helpful, because, I feel like if you get on a podcast and you can glean a couple of good points of information out of it, it was a successful podcast. That's typically what I'm looking for there. So that's really helpful. We're going to wrap in a few minutes. Just let me ask you, are there any questions that I should be asking that I'm not asking that you think an audience would want to know? I want to make sure I'm covering off on some of the big key points. Once again, focusing more on in-network.
Yeah, I think it's the avenues of approach, right? So we talked about employers, we talked about plans, what other... I think there's other potential opportunities for folks, again, to either get scale or to partner with different entities. In New York, we have a fantastic organization called Digital Health New York. Again, important to kind of get into an overall ecosystem. So are you working those channels? New York has a vibrant community. San Fran does, Austin, right? So there's some channels across the country that I think are, where folks can get ideas from and share ideas. I think those become very valuable too. So maybe, I think I already answered the question, but that's what I would mention though too, Lon, for sure. Very valuable to have those relationships. I gave a shout out to
Vytalize. I'll give a shout out to Digital Health New York as well, because I just attended one of their events and I thought it was really high value and I made some great connections there. You should be thinking about doing things like that. I'll ask you one last one. What about your health plan associations in your state, like the New York Health Plan Association and others? Do you feel like those are pretty good avenues to go down as well?
I do think there's value for those organizations, but keep in mind, that's the broad organization. Like each individual discussion will have to be with the plans. There's never going to, unless they decide to do some sort of corporate deal. But the one thing I wanted to mention too, actually, is you brought up a good point. what other aspect to go at? ACOs are really an important aspect to go at too. So I was negligent in saying that. You mentioned
about that
it
a little bit. Yeah. And you know me well in my day life a little bit, and ACO reach is a very focused area of mine. Can you talk a little bit about why that's so important, ACO reach and maybe MSSP?
Yeah, and even just any provider group that's under a value-based care program. So in essence, they are graded or compensated based on the performance of what they're doing, right? So if you have a solution that can, again, improve member engagement, improve an outcome, lower a cost, obviously plans are interested in all those things, as I mentioned, but any group. So Vytalize, I am in charge of the New York Independent Physician Association in Long Island. We have 2,500 physicians. We have numerous contracts. There's an opportunity if someone comes in with a better idea and I can go to my physicians and say, okay, well, we're grading on our performance. Is this going to improve our performance, lower costs, get better patient care? It's something that I may be interested in as well. So similar to other ACOs. And you do see a lot of startups approaching maybe ACO partners, even hospital systems. So these are folks now that are graded on the overall outcome of the care they're giving to patients. So there are solutions that can maybe help in that. So I think, again, we're talking about, the employers, the providers, the plans, but all three options are really, I think there need to be solutions for that if you have a startup for sure. I think that'll just benefit you.
Yeah, I completely agree. I mean, that's one, I think, nugget people can take away from this is, everyone thinks I have an idea and I want to go to a health plan and get it done. But health plans, yes, they're really important. But a lot of health plans take their sickest patients and they subcap that risk to someone else. So you may have a solution that's really good for high-risk patients, but 80% of those high-risk patients may be owned by a company like a Landmark or Prospero or SyncCare or someone like that, right? So you can talk to the health plan, which is important, but you should also think about talking to them because they have full financial responsibility for those members. So it's always important to follow risk all around. ACOs are a fantastic model to be able to go after. And quite honestly, probably one that's easier to get attention in than to get an attention in an Aetna or United, which is a behemoth, right? So the really good point that you brought up there, and I really appreciate that. Michael, is there anything else that comes to mind that you want to touch on before we wrap up?
I'm good, Lon. I appreciate the time.
Well, really quickly, how you kind of alluded to it. What's the best way for people to reach out to you if they wanted to learn more? I think LinkedIn. You might say LinkedIn.
You can find me on LinkedIn.
Find him on LinkedIn. And he's great about that. And I don't want to say very responsive because I don't want to put you on the hook for that. But I really appreciate you taking the time. We're going to wrap up this episode. It was another great episode. I think really high value. So thank you so much for being a guest. If you want to follow for more advanced content, go to healthcaregrind.com. And also please subscribe to the podcast and YouTube channel. We really appreciate it. Michael, have a great weekend. Thank you so much for your time today.
As we wrap up this episode of the Healthcare Grind, we want to thank you, our incredible audience, for tuning in. If you found today's insights valuable, don't forget to hit subscribe and leave a review on your preferred podcast platform. Your feedback fuels our grind. For more exclusive content and updates, visit our website, healthcaregrind.com. Until next time, keep grinding, stay informed, and lead the charge in shaping the future of healthcare. This is Jess and Lon signing off from the Healthcare Grind.